As many of you recall, when we launched the nation's first stay-at-home order on March 19th, its purpose was foundational, was to save lives and to better prepare our healthcare delivery system for an inevitable increase in capacity needs. And that increase was not only increase in terms of place, meaning identifying the opportunity to provide conditions where we can find physical assets for individuals' space, but also the appropriate number of people to help support individuals in needs and, of course, the appropriate level of personal protective equipment that is foundational and essential to safely providing that care. So as we move forward on March 19th of this year, we, with intention, began a process anew to identify those foundational components so that we can meet the needs of those that need to access hospital care and receive high-quality care in the state of California, and to look to utilize our existing hospital footprint, the capacity that exists within a hospital setting and within the larger hospital campus setting to build capacity. In addition to that, of course, we look to identify alternative care sites all throughout the state of California. You may recall a few months back we talked about FMS. These were the federal medical stations that we were able to get from the federal government. We identified locations throughout the state of California to pre-position those FMS sites that provide capacity up to 250 beds to meet the medical needs of the system, to help decompress the hospital system, to provide alternative care sites to meet the needs of patients that either were pre-symptomatic, asymptomatic, or in some instances were not in need of acute care, but need of intense medical care that may have been exposed to COVID-19. We identified additional sites throughout the state, including old mothball hospitals, Seton being an example in Northern California. We had identified early on St. Vincent down in LA County. We procured sites that are still under contract in Fairview and Porterville, different parts of the state, up here in Sacramento, the old Sleep Train Arena, where now the Sacramento Kings used to play. Those sites, many of those sites, still available to us in what we call warm status, all part and parcel of a larger portfolio to meet the needs as we see an increase in the spread and transmission of COVID-19. Speaking of spread, this slide gives you a sense of what our existing hospital footprint looks like in the state of California. We have 416 hospitals in this state. But one thing you'll see from the slide is they're not equally distributed in various parts of the state. Let me give you a specific example. You have roughly, plus or minus a few thousand, but roughly 21,000 plus licensed hospital beds in LA, as an example. In Sutter County, you have just 14. So depending on where you live, the assets that are available to you are quite distinctive. And you can imagine where you have an increase of just a few patients in your ICUs in Sutter, that can represent a huge percentage of your total capacity. So often I make this point in presentations like this. I give you information in the aggregate, but remind you that none of us live in the aggregate. We live in cities and counties throughout the state of California, populated with different density in terms of total number of people, but also different density of assets. And so over the course of the last number of months, we've been looking to procure strategies in a very strategic and mindful way of where those deserts of support were, from testing to tracing and tracking to addressing the acute care needs, as well as meeting the needs more broadly of communities throughout this remarkably diverse, the nation's largest and most populous state.